Starting our instruction course number 241, Refractive Surgery Options and Decision Making. And it will have three talks. One is the refractive surgery spectrum that I will take, and then second talk will be corneal procedures, indications and considerations for 20 minutes. That is for Dr. Bhupesh Singh to take. And the third talk will be lens-based refractive surgery options, investigations and considerations. That will be Dr. Purendra Bhasin to talk about. So it will be a comprehensive course of refractive surgery options where we'll talk about basically all the kinds of surgeries which are available in our armamentarium as of now. And these are actually very interesting times for a refractive surgeon because we have a large area, large options, large plethora of options available for us to manage every kind of refractive error which is available, from a small power of -1, which is probably the minimum you want to correct, up to whatever you want to correct, like 30 or whatever, because then you have options of bioptics and trioptics also. And there are options for very severe kind of disorders where you can do multiple surgeries to manage like abnormal conditions also. So we will be taking all the conditions one by one. And the overview of the refractive surgery is we have myopia, and to correct myopia we have corneal procedures like LASIK, epi-LASIK, PRK, LASIK, intracorneal rings and inlays, Scara rings which are no more used but definitely intact are still in vogue. Lens-based procedures like phakic IOLs and clear lens extraction with multifocal IOL implantation. For hypermetropia, we have corneal procedures like LASIK and surface ablation, and lens-based procedures like phakic IOLs. And I can tell you, with all these options, we are looking at an extreme level of accuracy of almost 90% people getting fantastic results and satisfactory results, and they are very happy to have. And for astigmatism, we have procedures, LASIK, other all laser procedures, along with query arcuate keratotomy. Why query is very few people are probably now practicing keratotomies, though I did keratotomies earlier in my practice in 1985 to 95, and a lot of arcuate, radial and astigmatic keratotomies in my practice with fantastic results. I still see these patients after 30-35 years of their procedures, and they are pretty happy. They come back to me for whatever problems, if there are any, they have, and they still consult, and they've been happy for more than 20 years, so they have a lot of faith. And for astigmatism, we have toric ICLs, which are now becoming the in thing, because lot of these procedures like laser and other procedures are they involve a lot of cost, both for investigations and also for the performing the procedure. So ICL is an easy procedure for anyone who is practicing cataract surgeon, and do an ICL without much investment in the machinery, but and give excellent results. Presbyopia is another field which is coming up very, very nicely, and we have presbyopic LASIK, press beyond and other things. Conductive keratoplasty has been given up as of now because these procedures were more kind of used almost 20 years ago, but now this conductive keratoplasty is no more practiced, but lens-based procedure like pre-lax presbyopic lens exchange and multifocal IOL is very much existent in today's world. And also recently there are a lot of people who are doing multifocal or presbyopic ICL for correction of presbyopia in patients of age group of 45 to 60, and they're giving excellent results unless there is a cataract development. For them, we'll talk about, if the time permits, we'll talk about the procedures which are available for presbyopia, including the ICLs. This is a radial keratotomy. If you have not seen it, these are the marks, and the radial cuts were made at a depth of 90% of the cornea, making sure that there is no corneal perforation, because if the corneal perforation develops, then there is a possibility of development of cataract or iris atrophy. But if there is a corneal perforation, very small micro perforation, which does not cause any flattening of the antechamber, then probably it's not a matter. One has to be very careful, because 90% depth is also very close to nearly, and if you press harder at one point, sometimes there is a little bit of oozing of aqueous, like in this particular case. And then you have to irrigate these cuts very gently, so that there is no debris remaining in these cuts, because this debris remaining in the cuts causes a lot of epithelial kind of nests, and can cause trouble in the later time. I started in 1992. I had a machine called ALK, which was making the flap, and the second pass, one pass will make a flap, and the second pass will cut the lenticule. This was the first procedure, lenticule-based procedure at that point in time, when there was no laser, femtosecond laser available, and you could regulate the size of the lenticule and the thickness of the lenticule, and correct very high myopia, anything more than 6 or 8 diopters of myopia. In all these cases, I don't have a video, though I might have done few hundreds of these ALK procedures in my time. The only problem was that it was not possible to correct astigmatism in this lenticule procedure, which was after making the flap, which was possible by doing with the excimer laser, but it was very accurate procedure, or not so accurate, but reasonably accurate for people up to about more than 12 diopters also. Sometimes I did, I think 14 diopters also in these cases. Depending on the thickness of the cornea, you could go up to correction of 14 diopters in these cases. And this was a decent procedure. This ALK keratome, I got it in 1992, and then in 1995 I got the excimer laser. That was the first excimer laser for LASIK procedure in the city at that point in time. And initially I used this auto ALK keratome for making flaps of 120 to 160 microns for doing a LASIK in my own practice. And it was decent. I think I continued with this for more than about 3 or 4 years, after which I purchased a dedicated keratome for making flap only. ALK was not actually only for flap, it was for like correction of myopia by creating a lenticule, and also correction of hypermetropia by making a thicker flap, so that there is a weakness in the bed, and there was a little bit of protrusion of the cornea in the center, though it was not very accurate, but it was correcting a little bit of hypermetropia, like 4 diopters or so, very peacefully. And also it was also lenticule, the ALK procedure was also good for making a very thick flap of 300 or 400 microns, or even that much, for a lamellar keratoplasty. So that you could take a thick flap, thick lenticule, flap, and then cut it according to your size, and then put it as a procedure for lamellar keratoplasty. Then in 1995, I had this LASIK, and this is a very old video, probably not recent, because at that point in time, this is the time when I started using that Moria keratome. So this is the time, and this is, everybody is doing LASIK nowadays, but this is one of the few, since this course is not complete without showing these procedures. So this is a flap creation and then laser, and as you can see here, the astigmatic correction was also possible with excimer laser, and that is why this came into vogue, because the results were very accurate and were very stable for a very, very long time. There was probably regression 5 to 10 years down the line, but not much to the extent that majority of my patients who were done almost 20, 30 years back, they are still very happy and they are coming back for their cataract surgery. Now they are in the age group of 60 or so, 55, 60, 65. So these were the, and also in LASIK, the advantage was, like in this particular case, this was a small aberration correction with the segmental ablation by Nidec system, and this was correcting the aberrations also in the cornea. So the quality of vision was also superior to just correcting the aspheric or spherical ablations. So this was LASIK, and then you wanted to kind of wash the interface so that there was no debris and there was no epithelial ingrowth after this. So gently I needed to wash the underface and then interface wash, and then put the flap back so that there was a smooth, adhesion of the flap on this bed, and then you could see the majority of these patients were seeing as much as the best corrected visual acuity the next morning, and they were very good. The wow factor was there. The wow factor with the radial keratotomy was also very good, and wow factor was with LASIK was even superior to what we had with the radial cuts. So this was another procedure which was available, and then came the after LASIK, when the ectasia was recognized, then we realized that there's not a good idea to make a thick flap, because the flap thickness was not as accurate as today's with the femtosecond laser. So we made a small well, and with the alcohol, and then removed the flap of the epithelium and ablated on the surface itself. The idea was that if you did a PRK directly, then because of the epithelium not being there, there was a lot more haze as compared to with the LASIK. So this was something which I did, and with good. So in my practice initially, when I had the excimer laser, I never did PRK, because I was not convinced with the kind of haze, because at that point in time mitomycin C was not available, and since mitomycin C was not available, we did not have any control. And here you can appreciate that all the alcohol was taken away from the top, and there was no alcohol spillage on the area which was not meant to be touched with alcohol. So but any case, PRK I did not do initially, because of the reason that I was not convinced, because of the brown irises and our tendency to develop more reticular haze. But with the LASIK, when you removed the epithelium with the alcohol or with the epilasic, the epithelium, when it was put back, it took care of the the reticular haze, and not much of reticular haze was seen, and also it was not having a lot of pain also, because the exposure of the nerves was not very much. So both ways, this epilasic and LASIK alcohol induced corneal flap of epithelial flap was very successful in taking care of the epithelial haze, corneal haze, reticular haze, and also the 20 minutes. कितना टाइम हो गया? 20 मिनट्स हो गए? नहीं, 20 मिनट्स पे तो so this epithelium was reflected back like a flap in the LASIK, and then laser was performed, and then I'll take it forward so that, and this way the laser was done, you know, having a Marusel sponge on the epithelial flap, which was otherwise also pretty kind of thin. And since these patients, this was done in all the patients which had higher power. So that is why you can appreciate that was much smaller ablation zone with much deeper ablation. And both astigmatism and spherical powers were were able to be corrected in all these cases. So then after that, a little bit of mitomycin C with the sponge. So this was very important because when mitomycin C came into picture, then only we were able to take care of the reticular haze, and then I started doing surface ablations. Before that I never did, because couple of cases at that point in time, initially I saw the other surgeons, they were having only -2 to -4 power, but had developed a reticular haze. Maybe because of the broad beam lasers which were available, maybe because of the fluence of the laser was not as good as otherwise, but reticular haze was seen in quite a number of patients, and in all those patients even a retreatment will not take care of the reticular haze. So that is why this was something which was there. And after that, remove the mitomycin C sponge and put the flap back very gently, and this will take care of the, and after this you put a contact lens. But the beauty of this thing was that the haze was not there and pain was not much as compared to what we see in trans PRK today. The pain was not the matter at that point in time with LASIK, or so then you put the contact lens over the, and that was it. And then came the femtosecond laser LASIK. Okay, I'll skip this. I'll continue with this procedure, this here. So this was the the femtosecond laser. In my case, it was a Z LASIK, only because the reason that Zimmer was the machine which I had by, and they called their procedure as Z LASIK, the Zimmer LASIK, the femtosecond laser. So there was this cone which was to be centered on the cornea, and then initially this Zimmer machine had a raster pattern of laser cutting the flap. So it was like laser going this and then this and then this, like this. Multiple time it will go across. Here you can appreciate that multiple time it will go across and make a linear cuts in the, with the edge here. So these were the linear cuts you can appreciate, and then this was the edge which was created. This is very early in femtosecond laser LASIK. This was in 2007. This video belongs to that time. And now the laser which is available for making the flap and the lenticule, they go round and round and make the cut in a circular manner. But that time it was a raster pattern, and the adhesions were a matter of significance. So you could not lift the whole flap at one go. So gently you had to kind of separate and break the adhesions initially, and then one or two swipes it would take to lift the flap completely. And then after that the same excimer laser will continue for this procedure, like here. After lifting the flap, you could do a excimer laser correction. At this point in time, around this point in time, there was a iris pattern capture, and also pupil center capture was also available. So after some time, there was not much of an issue of decentered ablation. Initially, the decentered ablation was a problem in LASIK, but later on, when the pupil capture and iris pattern capture, the correction of the astigmatism and also correction of the or centration of the ablation was not much of an issue, and it gradually became more and more accurate, more centered ablation, and then same thing which was kind of there before. So this was something which was, and the femtosecond laser flap, which was more or less absolutely planar flap, not like a meniscus with the keratome. So the thickness of the flap was perfectly same all around. So the chances of thinner flap in the center and flap stria was also taken care of. These flaps were much more accurate, much better. Size was much under control. Whether the corneal curvature was flatter or steeper, the size of flap was very accurate. And then this is a procedure I just wanted to show that this is a procedure where I had done a keratoplasty, and when I am doing this, flap is going beyond the keratoplasty scar. This was a young girl when I did the keratoplasty. In early cases, the girl was around 5 or 6 years of age. I did the keratoplasty, and then after that, this is the laser going on. As I explained, this is a raster pattern, and once we made the flap, the laser was very efficient even in the areas where corneal opacity was there, and flap was not torn because of the corneal opacity. So the accuracy of the femtosecond laser is very nice. Even in radial cuts and all, you can do the cataract also in all these cases. And now the most recent thing is the smile. So this is the smile which we got in 2018. This is another procedure which is available and very accurate, and I'm sure quite a number of people have seen smile and other procedures which are lenticule procedures. Now there are 3 procedures available: the smile, the elita or silk, and also the clear. The clear procedure is also available, and here we do a dissection of the lenticule, anterior plane and the posterior plane. Both are separated one by one, and then you pull the lenticule out. Like a little bit of adhesions if are there, then you can just pull them out by doing a rhexis kind of tearing, and that is done. So this is again a new procedure which I got recently about 5-6 years back, which is called clear. So clear is, here is the animation of the clear procedure. There is a vacuum you create, and then, sorry, what happened? Yeah. And the centration in clear is immediate. The axis of the clear procedure is, once you have marked 180 degree at 180 degree at the cornea, in the periphery, the machine captures the 180 degree axis perfectly, and then, why it is not right? Okay. And then it cuts the posterior and then the anterior plane. The beauty of this clear procedure is the distance, working distance is smaller, focus size is smaller, and also the separation of the pulse is not like other machines in Zimmer or Silk, Zeiss or Silk. So here the separation is, they are overlapping spots, so there is hardly any tissue adhesions, and you can have two ports to dissect the lenticle, and one by one you can dissect the anterior and posterior, and then you can probably either pull it out, or you can just push some BSS, and the lenticle comes out. So this is, here it is. You have to prepare the laser before you can do this, so that you have to put the SIMK values, and also put the Q factor. So Q factor comes in the pentacam, it is minus 0.22, and then pachymetry you have to fill in the machine. Once you have put the pachymetry reading, then the power to be corrected, and I have personally corrected minus 4.5 astigmatism with this procedure. Here in the initial stages, this is the 2.5 with and there was hardly any target refraction. We always wanted to keep something like 0.25 on the positive side, so that there is, even if there is a regression, so there was no problem on that. And then you cut the anterior and posterior planes. It captures the pupil, captures the 180-degree axis, or if it is not capturing the center of the pupil, you can make it in the manually, you can center the machine laser ablation, and then you cut, whether you want to cut 2 ports or single port, depends. If you are comfortable, you can make 2 ports, or you want to make 1 port, that is fine. Or you can make 2 ports and use 1. That is also possible. And then it cuts, and also the beauty of this system is that there are, if you see, there are 2 venting tunnels. So the earlier machines had a problem that these gas would vent into the antechamber or above and rupture the cornea. So in all these cases, the venting was something which was helping for the gas will not escape from other routes except for where you want it to go in the venting tunnels. And once it has done the cuts in the anterior and posterior, you can create the port, and after that you can go through this port to take the lenticule out. And I can tell you, this lenticule procedure is also very, very accurate. Majority of times you will find that all these patients are nearly 6 the next morning. So this is very, very accurate procedure. And there is initial few cases, 10 to 15 cases, where you need to kind of optimize the energy and optimize the laser and find out what kind of errors you are looking at. Once you have done those 10 to 15 cases, after that accuracy is very nice and you can be very confident. We are using it for now 5 years, and with utmost accuracy. I am doing SMILE for a longer period, of course. Clear came much later. So you can do the separation of the, and here I made 2 ports, but there is no need to use the second port. The lenticule is being separated, the posterior plane, and once you have separated the posterior plane also, you can pull the lenticule out. Initially, you need to pull the lenticule out, later on with the crocodile forceps, but later on you can just push it out with the flow of BSS. So suggested treatment algorithm, I have already talked about that, but patient with sufficient corneal tissue, all kind of LASIK or clear or lenticle is possible. Insufficient corneal tissue, epi-LASIK, PRK, submovement keratomeleusis or femtosecond laser. As a law, you cannot do a normal LASIK for anything less than 490 micron corneal thickness, normal. So you cannot do a microkeratome LASIK even if the power is low. So mind it, you can only do a surface or other than the normal LASIK and especially femtosecond laser. And then in insufficient corneal thickness, the choice probably between phakic IOLs and clear lens extraction. Low myopia who require reversibility, you can do ICL, presbyopia, presbyopic lens exchange or presbyopic LASIK or presbyopic ICL which is now available. And then hyperopia, wave front guided or ICL, and astigmatism, we all know excimer laser based or toric phakic IOL or intracorneal rings, especially in the cases of keratoconus. So conclusion, various treatment options are available. Customize the treatment to the patient needs, and also you can have a bioptics so that you can correct a larger correction. Current options, as I've already discussed, bioptics. Thank you very much.